Well, here we are back at chapter 25. It is a two-part series on hematologic emergencies. Now, hematology is the study of blood and how it functions in both health as well as disease. Now, recall that blood is made up of a few components, red blood cells, of course, that carry the oxygen. Then we have the white blood cells that are used to fight infection. We have platelets that help with the clotting process. And then we have some clotting proteins that help to control bleeding and speed the healing process. The hematopoietic system is made up of organs that produce blood, mainly bone marrow, the spleen, and the lymph nodes. And then we have hematologic disorders, and these are conditions that affect blood. These are going to include hemolytic disorders, where red blood cells break down too early, and hemostatic disorders, which are problems with bleeding or abnormal clotting. Remember that blood is a type of connective tissue that is made up of cells and cell fragments floating in plasma. It makes up about 8% of your total body weight, which is roughly 5 to 6 liters in an average adult. Blood plays a big role in keeping the body running smoothly. Its main jobs are, of course, to deliver oxygen and nutrients, as well as remove carbon dioxide and other wastes. But it also carries hormones to the target tissues, like we discussed in the previous chapter. It helps to regulate body temperature. It balances the pH level by using the buffers that it contains, and it keeps fluid and electrolytes in check. Another thing that it does is it helps to support the immune system by carrying those white blood cells and antibodies around, as well as it provides clotting as a means to be able to stop bleeding when needed. Plasma, there are two main parts of blood. Plasma is mostly water. It's about 92% water, and then it contains proteins, electrolytes, some clotting factors, as well as glucose. This makes up about 55% of the total blood volume, so plasma takes up essentially the majority of blood. And then we have these formed elements. It makes up the other 45%, and that's going to include red blood cells, white blood cells, platelets. Of course, red blood cells make up about 99% of this portion of the blood, so the bulk of the formed elements is actually going to be red blood cells. And this figure here, it kind of shows the components of a blood sample. There on your left, you can kind of see where the components, how those components kind of shake out, and, how they're divided up, and as well as the development of cells in that hematologic system and how they kind of develop. So red blood cells are made from stem cells, and their production is actually triggered by other components. One of those is called erythropoietin. And I'm probably not saying that right. It's a hormone that's released by the kidneys when the oxygen levels get low, and it tells the body to produce more red blood cells. And now it takes about 5 days for a red blood cell to mature, and they live for only around 6 months, 120 days. Inside the red blood cells, they contain hemoglobin, which contains iron, and this is what carries the oxygen to the tissues. That oxygen is also what gives the blood its red color. The Bohr effect is when red blood cells reach an area of high carbon dioxide and low pH. They release that oxygen because of this Bohr effect. This actually helps to deliver oxygen where it is needed the most. It's just kind of what red blood cells do. They sense that high carbon dioxide level and low pH level, and that's when those oxygen molecules will disembark off of the hemoglobin of the red blood cells. There are 3 common lab tests that we use to evaluate red blood cells. One is RBC count. This measures how many red blood cells are in a particular sample. Another is a hemoglobin level. This tells us how much oxygen carrying hemoglobin is inside the red blood cells. It is possible to have a low hemoglobin and a normal red blood cell count. That's why they're measured in two different measurements. Hematocrit shows what percentage of the blood is made up of red blood cells. A healthy balance usually follows this general rule. Hemoglobin is about 1/3 of the hematocrit, and red blood cell count is about 1/3 of the hemoglobin. So based on that, that's kind of where they say this is normal, this is where you need to be. Alterations outside of that usually indicate that there's something that's gone amiss. So this table here just simply shows the breakdown of red blood cells and platelet counts and kind of how all those different components, what values are normal for those components. Realize though, the thing to point out with this is some of those, like the red blood cell count, is going to be different in adults versus children, whereas hemoglobin is going to be different in females versus males and children. So those levels are going to be a little bit different. It's not something that we typically need to worry about in the field, but as you're perusing a patient's chart, maybe on a transfer, you might notice some of these values listed in there, and knowing the normal is helpful. Usually the normal on a lab value is listed next to the actual value that the patient has, and then there'll be a reference to what normal is based upon their age and sex and those kinds of things. It'll be a little more specific to them. White blood cells are actually larger than red blood cells, and they are key to fighting infections. Like red blood cells, they come from stem cells and develop into different types, each with a very specific role in the immune system. Some diseases target specific white blood cell types. For example, neutropenia is a low count of neutrophils, and it's which is the most common type of white blood cell. So that disease is very specific to that particular type of white blood cell. The immune system works in two ways. We have humoral immunity, which uses antibodies or immunoglobulins to recognize and target specific invaders. And then we have cell-mediated immunity, which uses macrophages and T cells to attack and destroy harmful cells directly. Getting into the study of white blood cells can be complicated at best, and it can be confusing. So just kind of accept for now the kind of just the overlying arch of what white blood cells do, and their primary goal is for immunity, and there's a couple of different types, humoral and cell-mediated, without getting too far into the weeds. This table kind of shows those white blood cell count differentials, shows you normal levels of each one of those, and you see neutrophils, basophils, eosinophils, lymphocytes, monocytes, all of those that are kind of contained in there, and what the normal levels for those are, and there's an indication of if things are outside, if they're low or too high, what may be going on with that patient. Just because a level is outside of the normal doesn't necessarily always mean there's some crazy disease going on with them. It just may indicate that there's further study that may needs to be done to determine what's going on. Now, platelets, they're the smallest of the blood, the formed elements in the blood, and they also come from stem cells. About 2/3 of them circulate in the blood, while the rest are stored in the spleen, kind of a rainy day kind of thing. We're going to store these for when we need them. The main job is to stop bleeding by forming clots. To give a kind of an idea of how that works, basically the platelets are going to form an initial plug at the site of the injury and just try to get everything stopped. And then clotting proteins are then kind of reinforce the plug and work to complete the clot. Thrombocyte is when too many platelets are made, or thrombocytosis, is when too many platelets are made, which can lead to clots or thromboses in areas where they shouldn't have them. The process of stopping bleeding is called hemostasis, and that involves vascular spasms causing the vessels to constrict, the platelet plug formation, some coagulation, which is the actual clotting, And then fibrin is the key structural part of a clot. The thrombin converts fibrogen to fibrin. And then, of course, calcium helps bind everything together. Ironically enough, some of the anticoagulants or clot busters actually works on the clotting or the calcium side of that to begin breaking down those clots when they're somewhere where they shouldn't be. It's what we used almost exclusively for patients suffering from an MI before stents were a thing. The clotting cascade is the step-by-step process of how clotting factors activate each other to form the fibrin and seal the injury. So what happens is this whole system kind of gets set into place, and it's called a clotting cascade that makes all of that work and creates that clot. The clotting cascade or the coagulation cascade, this is that clotting process, and it can start through two different pathways. There's an intrinsic pathway, which is triggered by damage inside of a blood vessel, and there's an extrinsic pathway, which is triggered by some kind of external trauma. Both pathways lead to the same result, which is the fibrin formation and the creation of a stable clot. Coagulopathy is a condition that disrupts normal clotting and hemostasis. This can lead to excessive or prolonged bleeding. One example is the von Willebrand disease, where a missing or faulty clotting factor causes bleeding issues. So the body doesn't have the ability to form clots like it should when necessary. Not necessarily, what we'd commonly associate with some of the other bleeding disorders. So several key organs actually support blood production and function. Bone marrow is the main site for making blood cells, and of course that's found in the long bones, the big long bones, the pelvis, even the skull and portions of the spine. The liver produces clotting factors. It also filters blood and removes toxins. It helps to regulate the metabolism and hemostasis. It breaks down old red blood cells into bile and gets them out of the body. But it is also highly vascular and stores some blood as well. So it's a little bit of a blood bank. The spleen is very vascular. It filters and breaks down red blood cells as well. It helps make lymphocytes. It supports infection control and hemostasis. And it stores about 1/3 of the body's platelets. So the spleen was once thought to be a relatively unimportant organ. It's become much more understood, in the last several years, and its role in the body is more important than once realized. Of course, this image here just basically shows the major players in the hematologic system. We see the bone marrow and the liver and the spleen and how they all kind of fit into the body. It's important to know these locations of these and knowing how vascular, especially the spleen and the liver are. So abdominal injuries, or especially upper abdominal injuries in the right or left quadrants, can be problematic and can lead to an extensive amount of bleeding abdominally. So when assessing a patient, start by looking for those life-threatening signs, especially the unusual or uncontrolled bleeding, which could actually indicate some kind of underlying bleeding disorder as well. Be sure to ask detailed and focused questions, especially when gathering a sample history. Before anything else, we got to make sure the scene is safe. Look for any kind of mechanism of injury and find out what happened and how it happened. How many patients do you have? Of course, watch for any hazards and decide if you need any kind of extra help. At minimum, we should be wearing gloves, mask, eye protection for our own safety, especially when we're talking about hemolytic emergencies, when there may be a bloody scene or lots of blood kind of splashing about. Start with cervical spine stabilization if there's a chance of any kind of spine injury on our primary survey. Don't ignore spinal pain. Even if it might be related to a medical condition, it still needs to be taken seriously if there's a suspected trauma. Form your general impression of the patient. Quickly get through your ABCs and find any life threats right away. Do a rapid full body scan and make sure that to assess the patient's level of consciousness. If the patient's having trouble breathing or shows signs of altered mental status, oxygen may be indicated. Use caution with suctioning or using airway devices, and avoid causing bleeding, especially if there's a bleeding disorder present or you suspect that there might be a bleeding disorder. Watch for signs of shock, like a fast pulse, low blood pressure. If they have hemophilia or a bleeding disorder, be careful with IV fluids because you don't want to wash out any existing clots that may be trying to form. Look for red flags such as sudden unexpected bleeding, signs of blood loss, and symptoms of hypoxia. Remember, with these patients, we're not going to try to get their blood pressure up to like 120/80. We're going to get them just above 80 and get them to hold their own so we're not washing out any clots that they may have formed. Treat any life-threatening issues immediately. And of course, we want to make sure that we get the patient to the facility that's most appropriate for them as soon as possible, especially if a hematologic emergency is suspected, but don't hesitate to take them to the closest hospital if the patient requires emergent stabilization. When we're taking a history, remember, hematologic disorders can show up in very unexpected ways with symptoms that might seem unrelated to a hematologic disorder at first. For example, a patient with sickle cell disease may come in or may complain or show signs and symptoms of pneumonia, and someone with polycythemia might complain of abdominal pain and kind of have us looking in the wrong area for the actual cause of what's going on. Keep a broad differential diagnosis on these patients with some of these diffuse things that are going on, and pay attention to those subtle signs of this isn't adding up. This is when we need to dig a little deeper into the history, because this can reveal important clues about what may actually be going on with this patient. Patient with sickle cell anemia that's showing indications of pneumonia, we should be thinking they may have pneumonia, but we should be looking a little bit deeper at some other sickle cell issues as well. So when taking history, ask about subtle or unusual symptoms that could point to a blood disorder. Things like changes in consciousness, dizziness, vertigo, fainting, shortness of breath, irregular, unusual pulses, coughing up blood, blurred vision or other changes like that, muscle pain, joint stiffness. These can actually be indications of other disorders, but they do fall into that realm of blood disorders as well. Even if these symptoms seem unrelated, they could be key indicators of a hematologic issue. So now what we want to do, we want to determine if the patient's complaints are interconnected as part of a broader disease process, or if they're representing multiple unrelated issues. Oftentimes we get patients that have multiple issues going on, multiple disease processes, and so this isn't unusual that we have things that are overlapping, and we need to kind of unlayer that to figure out what's exactly going on. Determine whether the pain is localized to a specific area, or if they are experiencing pain that's kind of dispersed throughout the entire body, because this might be paint a better picture of what's going on. Ask them whether they have experienced any of the following, such as changes in skin condition, any issues with bleeding, unusual bleeding, pain that is unknown, issues may be related to the genitourinary system, and even gastrointestinal concerns that they may have. Your secondary assessment may be conducted at the scene or during transport, or may not be performed at all. Conduct a thorough physical exam, identify common findings related to blood disorders, and record those baseline vital signs so that you have something to refer back to if the patient's condition changes. When it comes to reassessments, conduct frequent reassessments to monitor any changes in the patient's conditions. Communicate relevant information to the hospital staff, including patient history, the current situation, assessment findings, and interventions performed, as well as the outcomes of those interventions. Ensure that you comprehensively document the entire patient encounter so that the staff can refer back to your documentation if they have additional questions of things they didn't think of when you initially dropped them off. Emergency medical care for issues related to blood disorders should include things like the administration of oxygen and fluids as needed, careful monitoring of the EKG, and of course, transporting that patient to a facility ideally that can manage them best, but if emergent stabilization is necessary, we're going to take them to the closest hospital. We should provide comfort measures and pharmacological interventions as needed, as well as psychological support. The first one of these that we're going to talk about, and the only one in this section, we'll talk about a lot more of them in part 2, is sickle cell crisis. This is a serious and potentially life-threatening hematologic disorder. Sickle cell disease is the most prevalent inherited disorder that we deal with related to blood. It predominantly affects individuals of African American, Puerto Rican, and European descent. As of 2016, approximately 100,000 people in the United States were living with sickle cell disease. The average life expectancy for these patients is about 42 years of age for males and about 48 years of age for females. The condition originates from a genetic mutation affecting the adult type hemoglobin, HbA. It can be inherited from both parents or from one parent. When inherited from both parents, there is a significant likelihood that the offspring will either have the disease or be carriers of that particular mutation. Defective red blood cells assume kind of an elongated shape rather than a smooth round shape. Some of them can be even kind of half moon shaped. This abnormal shape reduces the red blood cell's ability to carry oxygen because it doesn't contain as much hemoglobin, and this elevates the risk of hypoxia. These cells are also more prone to getting kind of stuck and bound together because they have more jagged edges. The lifespan of these cells is much, much shorter because they're not near as durable, and of course this increases the risk of anemia. And as mentioned before, the irregular shape can cause these to get trapped into small blood vessels, and this can result in thrombosis in different parts of the body. Complications related to sickle cell disease can include what's known as an aplastic crisis. This happens when the body temporarily stops making red blood cells altogether. Patients may feel tired, become anemic, look pale, and struggle with shortness of breath. They may also have a hemolytic crisis. In this case, there's a sudden breakdown of the red blood cells, which can lead to jaundice. A sickle cell crisis may manifest itself as a vaso-occlusive crisis. With this, the blood flow to an organ gets blocked. This can cause significant pain, ischemia, and perhaps even organ damage. It usually takes about 5 to 7 days to fully develop, and the spleen often gets affected because its narrow vessels make it prone to blockage as it removes damaged red blood cells. Acute chest syndrome. This is a vaso-occlusive crisis that comes with pneumonia. Patients often experience chest pain, fever, and a cough. If vaso-occlusion occurs in the brain, it can lead to a stroke. Splenitic sequestration crisis. In this situation, sickle cells get stuck in the spleen, blocking blood flow. This causes painful swelling in the spleen and a hard, bloated abdomen. It's more common in infants and toddlers than it is adults. So that might help you narrow down that, what's going on with that particular patient. An acute splenetic sequestration syndrome. This is a serious condition where red blood cells get trapped in the spleen, causing a drastic drop in hemoglobin. Symptoms are going to include painful abdomen, sudden weakness, pale color, rapid breathing, and a fast heartbeat. Patients are often facing a life-threatening crisis when it comes to sickle cell disease. When assessing these patients, look for signs such as shortness of breath, symptoms that indicate pneumonia, poor skin perfusion, which is often seen with low blood pressure, signs of jaundice, yellowing of the eyes, and mild dehydration can all be possible with these patients. That combined with a history of sickle cell should start to give you some indication of the severity of what they have going on. During an acute crisis, patients often experience significant pain and may have multiple systems affected. In pediatric patients, the initial pain usually starts in the hands and feet. For adults, the pain commonly occurs in the back and in the proximal extremities. Management for these patients, the first step is to help the patient find a comfortable position. Cover them with a blanket and keep their body temperature steady, as cold can actually worsen the sickle cell crisis. Administer supplemental oxygen to help support breathing, and if needed, provide IV fluid therapy to help with hydration. Offer analgesics according to local protocols, but keep in mind that patients may have a high pain threshold and might need a stronger dose of pain medication. Encourage the patient to rest during transport to minimize their discomfort. And there you have it. There's part 1. We will be back with part 2.